What up, everyone? Welcome to Live with Nekky Jamal. I have a super awesome guest today, and I'm really pumped up to finally meet this dude. I'm sure you've been following him along on the Bytes Global Implant Network. I have the legendary Alain Gagnon. I hope my Francois, whatever pronunciation is good. But man, I don't want to pump his tires here, but this is the dentist I want to be, in 10 years out when I'm at the same stage of career as Alain is. And he has an incredible surgical practice. His soft tissue grafts are impeccable. And without further ado, I have the Alain Gagnon. How are you, my friend?
Very good. Thanks for these nice words.
No, man, no. Honestly, it's an honor to meet you. But not everyone knows you. So tell us about yourself. Where do you live? Where do you practice? And how'd you get there?
So I grew up and live in Montreal, Canada. So I've been in Quebec province all my life. I went to dental school, University of Montreal in French. So most of my career is involved in French. So um, yeah, I started the dentist like in 92. So it's been 28, 29 years doing dentistry. And dentistry was like, I don't know, combination of my interest in biology, engineering and medical field, and I end up to in the dental school. And I did like it first day from beginning to the end. And I managed to finish dentistry. I was 23 years old. So that
What?
was pretty
Wow.
quick. Yeah.
And you've been in this game for 30 years, 29 years, hey?
Yes, yes, yes.
Do you still have the same passion? Like, how do you energize yourself all the time?
It's up and down,
Yeah.
part of my life was just doing dentistry for learning the stuff. When in those years, it took times to get the knowledge. There was no internet, no videos, no fancy stuff like right now. uh, so I think the first 5 years was just be happy to try to do what I just learned at the school. But after another 5 years, you plateau and you decide. My quest for learning started when I was probably in my mid 30s, and with young kids at home. I invest a lot of time learning, but you have to take the plane, go some in the institute there and there. It took a while to decide what I wanted to do. I started on a journey with ceramics, veneers, full mouth rehabs. So that was my second 10 years of practice after doing like basic dentistry for 10 years.
Really? So you went big into the prosto side of things.
Yeah, I went to the prosto side of it because prosto was always something I liked to do, but
Yeah.
step up a notch and learn about ceramics, prepping veneers. Uh, remember early 2000, adhesion was a big thing, composite was a big thing. So veneers, Emax just came out on the market at that time. So I've been placing Emax for 20 years, but the first 10 years, Emax was not there. The option was not as great, as strong, and people were really on the fence with those all those ceramic crowns and things. Everything broke at that time pretty often.
So you had your fair share of failures right off the bat and you
Yeah,
learned to deal with them, hey?
yeah. At that time the strongest ceramics was Empress. No, Empress is
Right.
half as strong as Emax, but I was doing Empress on molars. So
Yeah.
we had nothing else much to do. PFM and Gold Crown was still very, very often. Um, at, at that time, those doing those big cases, with older patient, most of them were missing teeth, and I was sending them to perio or surgeon to place some implants. And I said, oh, I need to learn about those because it looks like I can do it.
Yeah.
So I went to the surgical part of it, and so I was doing rehabs with surgeries, and slowly, I don't know why, but surgery was always came out, and and the more I learned surgery, the more I wanted to do, and I just dove into the surgical part and did all the Mish courses, Picos, Salama in about 2 years.
Really? So you
So
you just
yeah,
dove into it and
yeah, I
you
just
just
dove
took
into it.
so you changed your cosmetic ceramic prosto practice into a surgery practice.
I didn't change it. It just evolved to that direction. And I'm still doing prosto. I'm still doing cases, but that's not my main focus anymore. I like surgery more. So I
Yeah.
try to devote my time about 60, 70% surgery, and the rest, I need to restore all those implants. I'm do it mostly myself.
Yeah. I find it's like when I jumped into surgery, I found I didn't. You've heard of the term, jack of all trades is the master of
Yeah.
none. And
Yeah.
I found it hard to keep up with the prosto. Like I've done COIS, I've done all a ton of different prosto courses. I never fell in love with it. I just jumped into surgery and I found, everything started making sense to me and you get comfortable. And I know you feel the same way. But it seems like you're still super proficient at prosto. That's why I'm saying like you're the dude I wish I was.
Yeah, but I spent 10 years learning prosto, so
Yeah,
I have those skills. And implants is a prosto game with a surgical part. So
that's
if,
right. Yeah,
if you don't do the prosto properly, you're gonna have some failures, aesthetic failures, occlusion failures. I see so many implants that are just stick in the bone and hope the lab will deliver something good. That was pretty much the norm of about 20 years ago, 15 years ago, and still probably still probably pretty high.
yeah,
It's very fancy to take a weekend course, learn to put an implant, but the rest of it is pretty important. And I
yeah.
think soft tissue should be learned at the beginning when you start to do implants.
I totally agree with that statement because I find as I do more implants, I go back to my previous cases and I'm unhappy, and it's mainly because of the soft tissue. And you're totally right. They should be teaching soft tissue first, but soft tissue isn't as sexy as putting an implant in the bone, right? And that's why it's
Yes,
neglected.
it's neglected. I'm involved in the ITI study group in Montreal area, and I was chosen to teach soft tissue because a lot of new dentists they place implants. Even though they place implants for 10 years, now they got troubles. They asked me, what do I do with this implant? It's missing soft tissue, and it's always the same answer. It's missing soft tissue. So soft tissue around implants is, as I've been trying to mentor and teach that with my group the past 3 years now, and I'm having a lot of fun doing it. So that pushed me doing more surgery because I want to take pictures and share the knowledge. I'm at that point. I want to share my knowledge. I learned so much. Now it's time to make the others learn.
If Mark Kwan is listening right now, which I'm sure he is, I've been telling him, I'm like, man, get Alain out west and get him teaching a course because you are the guy I want to learn more soft tissue procedures from because you're a GP just like the rest of us, and I want to see what works in your hands. And I'm really excited for that day, Aaron. If even if that course doesn't happen, I'm just going to come to your office and you're going to teach me. Um, but I want to dive into soft tissue because you're totally right. Soft tissue sets the entire future, longevity of that implant. Because when I look at my failures, I've been practicing for 13 years. I have my 10-year implant cases coming up, and I'm not gonna lie, I've got failures in there, and we all do. But if I go look back at them, say they're locators, it's all because I didn't have any keratinized tissue. Do you agree?
Yes.
Yeah.
Yes, I agree. It's hard to sell soft tissue to the patient who wants a denture with implants locator. They're tired of the surgery. They've been waiting 4 months for the implants, and now you're doing the prosto. Somebody else is doing the denture for you, and you deliver those locator, and man, there's no soft tissue there because they lost the teeth so long ago. There's nothing. And those cases, I see them with thread exposure, pain when they try to brush the area. So I think soft tissue should be more presented to the patient when you start. Sometime I said after 4 months we're going to reevaluate your situation, but I think soft tissue will be needed. Sometimes we're lucky, we don't need it, but most of the time we should add some.
Yeah, and I think a lot of us dentists say, like, in the back of our heads, we're hoping our patient doesn't need it because we're not confident in
Yeah.
delivering those soft tissue solutions, especially in edentulous cases on the lower when you have basically no vestibule. You have to do a free gingival graft with a vestibular deepening procedure. It's difficult unless you know how to
It,
do it.
it, it is difficult, but it's a very very needed procedure. And I
Absolutely.
learned the basic with Picos just after I did all my surgical and prosto training with Mish. Um, and Picos was doing those huge vestibuloplasty, and he's a surgeon. He's doing very extensive surgery, and after seeing him a few videos on that, I say it's not a very very difficult area. The worst case, you go back to the same. You don't lose much. And vestibuloplasty and deepening of the vestibule is actually not. It's intimidating, but it's not that difficult.
Yeah. And I think it's intimidating. You're totally
It
right. Because
is.
my first couple, I was like, you're almost like you're making your incisions in no man's land, and you're
Yeah.
basically into the mentalis, and you're trying to
Yeah.
figure out where to go, and it's not fun unless you know what you're doing. So I have tremendous
Yeah.
respect for everything that you're doing. But
But
I wanted
if you place implant there, you're doing about the same surgery.
that's very true.
So you're cutting the same fibers, you numbing the same area. You have to avoid the nerve. You have to be careful. So I think it's about the same surgery. I learned soft tissue in the hard place. I learned soft tissue in my aesthetics veneer cases. So
Ooh,
adding soft tissue to a full set of veneers on canines because aesthetic is not right, that was much more challenging because if you miss it, it's going to show. It's going to show. Underneath a denture, it's not too bad. It's
fair
not too bad.
enough. It's the aesthetic cases, and you just jumped right in. Can
I
you
was
tell me?
already doing the aesthetic case, and I was tired of sending patients to perios, and some were good, but some were not that good.
Yeah, I have tremendous respect for everyone. I hear what you're saying, but can you tell me your very first time you cut into the palate?
Oh, that was
Was
in
your heart?
dental school.
Oh, really?
Dental school. I
You
did
did a
two
you did
soft
a
tissue
graft
at the dental
in dental
school.
school? Oh
Yes.
man, that's
In
incredible.
92, I did two graft in dental school. I hope they survive, you don't see them after that much. Uh, Cutting the palate was very, very nerve-wracking, yes.
Yeah,
But at least you have the perio guy was there, so just in case.
right. But what happens when you're in your own office and there is no perio guy behind you? It's you.
Yeah, I did hospital residency when we did full. We did a lot of surgeries. We did Lefort surgeries. We did with the surgeon. So I saw so many bloods, so many things during
Yeah,
that year that cutting to the palate. I was doing very, very, very little graft. One tooth in the premolar area, very scarce. So I did that for 10 years, very small tooth. And
yeah.
now all the cases I do is five, six teeth at a time. You progress to those level. But my first
I
graft was so tiny, I think it was hard to suture in place.
you're and I think you nailed it right there. The smaller your graft is, I think the more difficult it is because it's
Yes.
hard to manipulate those tiny little tissues. And whenever I'm trying to do a free gingival graft of like a lower canine, and you're just taking the tiniest piece of gingiva from the palate, you're almost wasting your time because you just need to make it so much bigger, and it makes your life so much easier.
Yeah, and it happens that you take it so small, you have to take it again.
That's
So
so
I
true.
learned that part, numb the patient more and take a bigger pieces. Do I tell the patient that, oh, I need to start over? But, you have to do them slowly, get a mentor, and you have to do them. It's a good service for your patients.
I agree, man. Tell me, have you ever had any serious bleeding when trying to obtain a CT graft?
I did some bleeding, but not big. The worst I had was where with sinus lift. I remember a
Ooh,
case of sinus lift, and I nicked the artery, and there was blood on the floor, blood on the wall. That was scary. I phoned a surgeon and said, "What should I do?" On the palate, I never had.
whoa, whoa, whoa! You can't just stop it there. What'd you do?
What'd you do? Uh, I didn't have a electro surge.
Right?
So he said, open up more and crush the bone with the biggest hemostat you got, and crush the wall of the sinus, and you're gonna squeeze the artery, and it did work.
Yeah, yeah.
Uh, but that was pretty scary because I was placing implants, doing sinus lift, and I was like, I think I was not too bad, and I got this case. And the patient after that said, "Oh, same thing happened when they removed the tooth a few years ago, and they sent me to the hospital. So you should have told me that. You should have told me." So I was more scared of sinus lift for many years after that.
Yeah, no, I don't doubt it. It's just that one experience that bites you. It's like falling off
Yeah,
a bike. Unless you get
yeah,
back on right away, you'll always stay off, right? Like
yeah.
you just need to jump back into it. I've had those bleeds when taking out some lower eights once, and I was helping out another guy in one of my courses, and he was taking out a lower eight, and it was literally like someone was pressing the button on a water fountain and just
Yeah,
gushing. It's just it scares you, right?
yeah, it is.
But yeah,
Uh,
pressure stops all bleeding, hopefully.
hopefully, yeah.
Hopefully. But in the
Yeah. So
palate,
on
sorry,
the
go ahead.
palette, I'm very maybe I'm kind of lucky because I do what 150 graft a year, and the worst case maybe it took me 10 minutes more to control the bleeding. Um, so not too bad.
And it's just with pressure every time? Are you just
Pressure,
injecting
local
epi around there?
anesthesia. Yeah,
Yeah.
AP works. 150,000
Okay.
Lido.
Yeah.
You go very far distal, and you really put it there, and
Oh,
usually
so
it
you're not
works
just going around your site. You're going more distal.
distal of the site. I go around if
Ah,
small bleed, but it's a big bleed distal.
really? So you want to get closer to the greater palatine, right?
Yeah, yeah.
Wow, that's a good tip. I'm gonna have to definitely try that. Do you ever incorporate PRF into your soft tissue
No, I
pellets?
think you're gonna teach me that next year.
You don't do PRF?
No, I don't.
Oh my God, man, this is gonna change your life, man. This is gonna change your life. Okay, that's awesome. So I got you to bring up a couple cases,
Okay.
just because I want to share some cases with some people here, because I know you got some awesome cases. So why don't you go
Yeah,
ahead
there's a
and
lot of
oh
cases on bites, so somebody wants to see detailed cases.
yeah,
Um, so I got a couple of cases coming up. I think one of the most graph I do is upper canine is very very often that people are brushing those away or clenching or they're missing tissue, and I see this person is a friend of a friend, and her dentist told her there's nothing much to do. He was not a believer in soft tissue much. Eventually,
you know why people say that, right?
because
Because
they don't do them, but
we
just
don't
refer
do
the
them.
patient.
You're so right though, because we always say, unless we're willing to take on the case, we always say, it's not that big of a deal. You don't need to do that. It's all good. And I catch
Yeah.
myself saying that all the time. So you're totally right. It's because I'm not willing to jump into those cases unless I absolutely have to.
So, so a case like that for me, it's patient has waited too long. Too long. I don't have all the details, but I think maybe it's on the bite, for him, because underneath that soft tissue at the base of the canine, there's no bone anymore. When
That's right.
you end up like that in the mucosa, you're losing a ton of bone. Um, Soft tissue is very important to protect the roots, protect the bacteria, protect the bone. So I told my patient the soft tissue is like the roof on your house. It's super thin, but without the roof, everything underneath is going to get ruined. So if you don't have the good coverage, the soft tissue to block the bacteria, you're gonna have bone loss. So she got a lot of inflammation. This is after we saw her probably twice in recalls every 2 3 months to get the inflammation under control because it was a painful area to brush. Just send the patient to the perio if you don't do it. I send patient to orthodontist every single day. I don't do ortho,
Right.
but people needs ortho. Some cases of patient wants to see a surgeon for very complex graft or wisdom teeth that I don't want to do. I send them to the surgeon. I send away maybe a few% of my cases. If the patient has a good service, that's the gold. So if you cannot do the soft tissue, just learn it or find somebody that can do it. So upper canine is something that I do a lot. I just did one today, and this is the result a few months later.
Whoa.
I think it's 6 or 7 months later.
I
So he
love
has,
the bulk of tissue you got there. That's
yeah.
incredible.
That's one thing. Some people do small graft. I tend to bulk the canine quite a bit because they're gonna keep brushing on those, and I want this patient to have more tissue there for the next 25 years, 30 years, whatever. Um, Usually, soft tissue they last so long. This one of the procedure you can, if it's done right and the healing is good, you can tell the patient it's a one shot deal. You know, you don't touch it anymore.
So tell
So
me, what's
yes,
like, do you, so go back to the previous slide there.
yeah.
When you're looking at this, do you like, obviously you clean the root really well. Are you putting anything on that root? Like, are you putting tetracycline on the root? Are you burnishing it in?
Yeah,
What's your
I
root
try many
treatment?
things in the past. I try Endogain, I try tetracycline, and you know what? I do EDTA, and half of the time I forget to put it on. So good cleaning. Take your time. I take some time, a red diamond burr, and just clean very gently but very truly the area. Curettes, and when it's pretty clean, I put EDTA on it most of the time, but not all the time. And after that, in this case, I did the flap release of the frenum underneath and put a big piece of CTG underneath. And after that, I bring the flap down. So you can see a vertical on the distal.
Yeah.
It's probably not going to be there next year, but in the smile of the patient, it really doesn't show. And patient was so happy with the result that we did the other side, same situation next few months.
Now, tell me, when you use that red diamond on the
Yeah.
root, are you nervous about causing even more sensitivity to the patient if you don't get the full coverage?
Yes. If you think you're not gonna get the full coverage because the biotype of the tissue is super thin and you think you're gonna cover only half of the root, you can just clean that half and leave the other one alone. Just use curettes. I will use diamonds when the tooth is very rough and there's a big depression or old fillings there. I will remove most of the fillings, until I get to the roots. And worst case scenario, you have to redo small fillings 3 months later if the sensitivity on the tooth.
Okay, okay. That's incredible because I was always nervous to take a diamond along an exposed root that was already sensitive. And so it's good to know that you remove all the restoration and then you'll take the diamond on the root, EDTA, make sure everything's very clean. And it looks
Yeah.
like, now correct me, did you only do one vertical incision or are you doing two vertical incisions to bring all
In
the
this
tissue down?
case, I did two.
Yeah,
The mesial one doesn't show too much on the. I can see it, but doesn't show as much on this picture. I did two vertical and bring it down. In this case, because I wanted a good access for the frenum underneath, I want
yeah.
to go deeper on the release, and I anchor my CTG mesial and distal underneath the flap, and after that I bring the flap down. If the CTG is very attached underneath, is very very straight on the tooth, it doesn't move at all. The success is pretty amazing.
Yeah, so it's all about stability and
Yeah,
immobility.
stability.
Yeah,
Yeah.
no, I love it. Let's look at the next case here because
At the
I'm
end of the
looking forward to these
surgery,
ones.
if you pull, you need to pull the lips very hard, and it should not move.
Oh, really?
Yeah.
Oh, okay, okay.
You have good
You have to make
release,
sure you
yeah.
have good
And
release, eh?
when you bring down the flap, it has to stay there. Don't use the suture to bring it down. The suture just make it stay there. If the sutures are under tension, problems will arrive.
Wow, I would love for you, sometime in the next month here, next time you have one of these cases, show us how you're releasing it. And so
Yeah.
we can see exactly that. I think that would be so helpful. But let's look at the next connective tissue case here because I had questions about this one here too. So let's
Yeah.
jump into it. 3-2 to 4-2, a very common sight to see. Now I'm not gonna lie. Before you jump into this, I see this and I automatically think free gingival right off the bat.
Yes. this is what I did for so many years until I saw those guy that doing amazing videos, those Italian guy that's doing tunnels and release and those micro instruments. I was doing most of my graph with the 15 blades. Now 15 blades, it's so huge. I use 15C. I use microblades. I use specially designed tunneling instrument. My first graph were done with basic instruments, so the results were pretty basics. Just doing the sutures with 6-0. The first time I used the 6-0 Prolene, it took me 2 hours to do a few sutures. Now my 6-0 is my biggest suture I use. I use 7-0
Really?
sometimes.
What?
Yeah.
How do you even see that? Do you use loops when you're doing this?
I use loop. I use 2.5 loops. That's all.
Yeah.
But I cannot live without my loops. So,
Yeah. Man, that's in 7.0. You guys, man, you soft tissue guys. You guys are incredible. I use 3.0 nonstop all day, every day.
I
Don't give
use
me
3.0
anything
for
less.
my wisdom tooth, but
That's right.
that's it.
Yeah, man, I've seen your third molar cases. They're pretty badass too, man. I'm telling you, you're the dentist I want to be. I'm so excited to be talking to you. Okay, so show us
Yeah.
how you
My
treated
third
this case
molar
here.
was my entry to the world of surgery. I was doing them out of school. I was, when you start working, you don't have those full hours, and you work there and there. I was doing Saturday morning. I was going to different clinic and doing wisdom teeth because many dentists didn't want to do them.
Yeah,
I remember some Saturdays I was doing 16, 20 wisdom teeth, just to pay the bills and get some experience.
yeah. No, that's wicked, man. That sounds like I'm on the right track to become you now. So this is good.
Yeah,
This
yeah.
is good.
So yeah, wisdom teeth is a basic surgery, and after that you involve, you get more finesse, and you have to take your time to do those surgery. I used to book 2 hours for any graft I do. Uh, Now I book an hour and a half, whatever is the graph, one, two, three, four teeth, because I have a system. And I take pictures, and for me, a graph is a slow appointment, and I want it to keep it slow.
I totally respect that because right now everything is, hey, let's just cram another patient in there and get it
Yeah,
done as fast as possible. So no, I 100% respect that because soft tissue does need its time.
yeah.
I hear you.
I
So
I usually put my soft tissue 1 day a week, like in the morning. Now soft tissue, you can put it anywhere in my schedule. When I see soft tissue, I just smile and do it. For me, it's like doing a occlusal filling.
yeah,
I like to have scheduling my surgery any day, anytime. Today I finished with a soft tissue. Usually, 10 years ago, I didn't wanted to finish my day with soft tissue because I wanted to be prepared. Now I just go with it, and sometimes I decide during the anesthesia what technique I'm gonna use.
no planning, just jump into it. I love it.
That's it.
I
Like
love
wisdom
it.
teeth.
Like wisdom
When you
teeth.
Yeah, when you schedule a patient and you come back 2 months later or 2 weeks later or 3 weeks later, you don't remember exactly the case, but you just go and you do
Just
it.
jump in.
Yeah.
I love it, man. I love it. So show us this case here. What are we looking
So
at?
this case, I took a risk. I decided to do a tunnel and a CTG because the demand of the patient was, can you do it an aesthetic graft? Because I saw a friend or family members with this ugly, ugly graft. And I say, yeah, we can try that, but it's a bit more complex. But I got good tissue on one side, not too bad on the other side. Uh, didn't promise, you say we're going to try to do a CTG. So I did a tunneling approach, and I don't have the full case here, but this is the sutures.
Now,
So
now
this,
tell me, like when you have such thin tissue, I
yeah,
would be so nervous to jump in and do a CTG here. And I find in my hands, like maybe I got two meat cleavers here. I can only do an FGG in that area. I've tried to tunnel in this area and it just goes nowhere. I
yeah.
just end up tearing right through the epithelium. What tips do you have for getting into tunneling and becoming more proficient at
Don't start with a big case like that. Start with a
it?
smaller one.
Yeah.
Uh, Try the canine area because you're far away from the nerve. The tissue is always a little bit thicker, but it's curvy, so take your time. Uh, yeah, very thin tissue. You have to go very slowly. Worst case scenario, I tunnel through the sulcus on this one. You don't see it on this picture because I did nice sutures, but I tear the papilla in the front,
Yeah.
so it happens. I try to remove to go underneath each of the papilla, but the front one just didn't make it. So you just continue slowly, and you make the best out of it. uh, I had some my tears, so that's why I kept some 7-0 sutures, sometimes to just repair one of my instruments, go through the gums. It did happen to me. You just continue, you put your CTG. Even if you have a small exposure, the CTG will survive, no problem.
Yeah. Hmm. Okay. Like, tell me about these sutures. How did you use composite to bring up the suture?
Yeah, this I saw on the internet somewhere. There's a crazy guy doing some suspended suture. In this area, if you go back here, you have a shallow vestibule and you have a little frenum in the middle. When I tried to bring everything up, there was some tension. So I said, okay, if I let the patient goes, the tension will tear my sutures. So at the end, I took three. I did three more sutures that I just spot etch, put a little drop of composite there, and I just take a suspended suture and bring the center up, so that if that protect the papilla and my main suture, that was the goal, to keep it up as long as possible, so the first 2-3 days healing will be protected by those sutures. Those sutures have a little tension on them, but they're just there to protect the movement of the lips.
I see. I see. Now, do you use Copac to cover your sites or no?
150 graph a year. Last time I used Copac 5 years ago.
Really?
So I didn't never like Copac. I use it at dental school. I use it a few times. They came out with a new formula with a gun. You don't have to mix it with your hands. I did try it a few times, but I didn't get any better result. The patient complained about the smells, and when they move, they sometimes the Copac will pull on the sutures. Uh, I never like it, so I never use it.
Okay. That's so interesting because I've been to multiple courses and some people use it, some people don't. Whenever I've used it, it tends to just fall off right away.
Yeah.
But what about periacryl? Do you ever use
Yes, I
periacryl to
use
hold up
ton of
your
it. I
grafts?
use it on the palette. I use it sometime on top of my GBR when I have a membrane exposure, or I want my suture to be super tight, super seal. I use periacryl every day, but I
Oh,
don't
really?
place it directly on my graph, or rarely. I will put it on the palette most of the time.
How do you put it on a palette? You just kind of put it on just to help form that kind of tough skin over the palette?
Yeah, I use the Ricardo Kern technique. I put flowable on my palette.
What?
So if you,
Whoa, whoa,
yes,
whoa.
yeah, yeah, yeah.
I'm going to Ricardo Kern's course in Brazil in April.
Oh yeah, this
Yeah.
he's my mentor. He's one of my
Alan,
friends.
you got to come with me, man. You
Yeah.
can be you can be my mentor when I'm down there.
Okay, when are you going?
April, you're coming with me. I'll send you the details. This is going to be
Okay,
awesome, man.
cool, cool.
So
I
how do
just
you
spoke to him yesterday. I
what?
invited him to Montreal to my study group, and he said yes.
Really?
So
Wow,
yeah.
that's incredible, man. How do you use flowable on the palette? I'm curious.
Okay, that could be a 15 minutes lecture just in that.
Give me the Coles
Um,
notes. Give me the Coles notes.
because not. After I remove my I use many mix of technique. Let me just show you the result. So
Sure.
that's the result.
Incredible. Absolutely, because that is a difficult procedure to do. There's no question there.
So that's 3 or 4 years after. So the tissue is like nothing happened. It's very thick, very robust, and we have very high quality of tissue just by the boost of the CTG I put underneath there like 3 years ago.
Wow, That's incredible because my free gingival graft would look like a big tire patch there right now.
That's it. So that's what we wanted to avoid. So if you look very fast in the mouth of this patient, you don't see the graph, you know?
No, that's
You
an
don't see.
absolutely incredible result, and you made it look really easy there. I would have loved to be in your op and watch to see how you do it because that's a very difficult procedure to pull off, especially with that thin tissue. So, man,
Yes.
bravo, that's
So
phenomenal.
that was what that was of the one of the first difficult tunnel I did maybe 4 or 5 years ago. And since that I don't know, I lost count, you know. I do them every week now.
Man, that's incredible. That's so cool. To your next case here, this is the case that I think everyone came to see.
Okay.
SGG and implants.
Yes. Yeah, you spoke about that a few minutes ago. Locator cases or thing like that, very thin tissue. It's very hard to adjust the denture. It has the patient to brush. It's very sensitive. Uh, so this is a case. Lower mandible patient was in her 60s, lost her teeth many years ago, and what I did like 4, 5, 6 months before this picture, I placed four implants underneath there, and I decided to close it down because I didn't want to exposure at the same time with that kind of tissue around the healing abutment, and I was a bit scared of having a denture there. That patient was going for removable, so no all on four kind of case. But even if you do an all on four in those cases, the soft tissue is not good.
Right.
It's very, very mobile. It's very, very thin, and because the resorption is very high, the nerve is on the surface of the ridge. So
Yep.
the mandibular nerve is on the surface of the ridge. So I was more scared of doing my incision than anything else because if I push the incision more a bit more too distal, I will just hit the nerve. The nerve was on the surface of the crest.
Yeah.
So I wanted a very better tissue. So I did the. It took a while to do the incision very slowly. Try to bring a bit of the soft tissue on the lingual, uh, and I decided to do a vestibule deepening incision and attach it down. And after that, I did. Those patients are fun because when they have the denture on the top, you can take the biggest piece of the palate you can. They will never complain.
Yeah.
The denture will protect everything, and their tissue is very firm, and you can have a ton of it. So those patients with an upper denture and lower teeth or lower implants are one of the best one to start with. The risk of the pain in the palate is like zero, and you have tons of tissue. You can take it everywhere.
That's a
So this
great
is
tip. I like hearing that. Okay, so
yes.
start with patients with dentures on the top.
Dentures on the top are a great patient to do free gingival graft or any harvesting of tissue.
Man, I'm so excited to see this because this is what I strive to get and fall short every time. How the hell did you do that? That looks phenomenal.
Okay. So if you go and bite, the full case is there. You know, Mark was very impressed with that case. So the full case is there. All the incisions are there. All the sutures are
Man,
there.
I'm literally drooling right now. This is incredible. Okay, so man, you have to give us some more detail here. So, how did you pin down the vestibule? I
The
can see
vestibule,
sutures all along here.
yeah, I pin it down with, I think it's Vicryl 6050. Uh, I like Proline a lot, but when I attach the incision down on the vestibule, no, it's, how you call it?
Is it gut? Chromic gut?
It's not gut. I think it's Vicryl.
Okay.
I think it's Vicryl, PGA.
Okay.
So you do split incision and you just go slowly and you attach it down so it doesn't move around your. So this is the last step, but the first step is the first incision, bring it down, attach it on the vestibule part. After that, you measure what you need as a soft tissue. You go on the palette, you take the soft tissue, and what I did is I cut it so it goes around my healing abutment. Uh, so a bit like poncho style, but with a 15 blade. So And after that, I did a lot of time suturing everywhere, every direction, so there's no movement on that soft tissue.
Now, Alain,
And if you see, yeah,
can I ask you a quick question? When you
yeah,
did
yeah,
your initial incision,
yeah,
whenever I've tried this, I find it really, really difficult to make it split thickness because that tissue is so thin. You're almost against bone when you make that initial incision. Is
yeah.
that
You
fair to
need
say or no?
it is difficult. You need a very sharp 15. If you touch the bone, change your blade because it's already not cutting right. Uh, Put some tension on the tissue. The obtrugate help, but I take a plier and just grab the tissue and pull it down, and very, very, very gentle incision, and the tissue just open up by himself. No pressure. Very don't go directly to the bone. Go angulate a little bit and just very, very slowly, and the tissue just open up itself. But you have to put tension on the tissue, and you barely touch it with the blade. Barely touch it with the blade. If you go in a cutting movement, like going for it with that soft, that very thin tissue, you're gonna go through it. Don't touch the bone. And if you touch the bone, change your blade.
That's a good tip right there. That's a really good tip. I like that. Okay, so then you place like you want to attach with your most apical sutures. You're attaching your tissue to your apical base. Am I right?
Yes,
Yeah.
yes.
So how do you do that? And are you attaching it basically to muscle? How are you doing that? Because
I
there
try
isn't much
to,
vestibular space there.
yeah, yeah. You're cutting through muscle, and you attach it. You have to section some muscle, so you attach it a little bit more down, so you don't attach it, so it doesn't move too much. You
Yeah.
you need about 5-6 millimeters of space between your sutures on the vestibule and your healing abutment, so you can that will not move, so you can place your free gingival graft on a solid area. So yes, if there has too many muscles, you can use a scissors and with your little pliers, and you pull on the fibers and you cut them. So you need a very flat, very immobile surface before you put your free gingival graft. Placing the free gingival graft, it should just drop there and stay there with no effort.
Yeah. It's all about getting that immobility, like we were saying before.
Yes. Oh, it
No,
takes time. It takes
it
maybe
does.
before you put the free gingival graft there, probably gonna take 45 minutes for me to have it clean and tied down and everything.
So do you tie it down on the apical portion before you put the graft on? Yeah?
Oh yeah, yeah. The graft goes at the end.
Graft goes on at the end. I love how you almost scalloped that tissue around the healing abutment so there is attached gingiva interproximally too. Or
Yes, I did.
into the
Yes, this
implant. Yeah.
was on purpose. Since it was
Yeah.
on purpose, because I don't want to expose the bone much. That patient has already a very severe bone recession. If you see on both sides of the screen, you have those blue mark. This is the
Yeah.
nerve. This is the nerve right on
Oh,
top, right on top. Before I did the anesthesia, I was palpating the patient. I can feel it, and the patient has pain directly in this area. So I mark it down, and I just cut in between those two.
wow. That's incredible. Man, my next question is, do you always do this at uncovery or would you come back a year later and do it? Or would you rather just do it right off the bat at uncovery?
I prefer to do it as soon as possible to get rid of all the risk and get rid of all the surgery. If I put healing abutment and I see the patient 4 months later before I do the whatever prosto step is, and I find that tissue, sometimes I will even do it at 2 months. I place the implants, wait 2 months, place the soft tissue, 2 more months, and we're ready to go to prosto.
Okay. Now, would a patient be wearing their denture over this, or would you would just say, don't eat anything, just eat soup for the next month?
That patient, with all the risk, all these implants, all the sutures, all this stuff going on, no denture for 2 weeks. Sorry, there's the only way you're gonna have very good results.
2 weeks. Hey, that's it.
Yeah,
Just 2 weeks.
2 weeks is enough.
Wow. And then they can wear a denture over top after two
Yeah,
weeks.
yeah,
Okay. And how long do you wait until you take out the stitches?
2 weeks.
2 weeks, and then all the sutures
Yeah.
are removed. Man, this is incredible. Let me see the next slide here. What does it look like? Wow.
Yeah.
Man,
So that
if only I could do that. This is amazing.
So that's probably about 6 weeks after. I remove the sutures, wait another few weeks, and after that, if I do the prosto, in that case, I didn't do the prosto, but my colleague did the prosto. So I wanted I just took that pictures before I send it to him to say, okay, everything is nice, I like it. You can do the rest.
If I could do this just once in my career, I feel like I would just have a big check mark beside my name for the rest of my life. This is incredible because these implants are going to be good for life.
Yeah, that was the goal, to get tissue, you're gonna have a success. If I see so many posts on different forums and they ask those questions, do you have enough soft tissue? Yeah, 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 I got enough soft tissue, and they barely have 1 millimeters.
Totally. No, you go back and you look at your, 5, 10 year cases, all the ones that are doing well, you have 3 mils of attached
Yeah.
tissue all along the buckle. It looks phenomenal. Like this is incredible. Great
I
job.
do graph the case I've done 15 years ago, because at that time I was just happy to place the implant. There's bone.
Right.
I was doing GBR, was very happy with the results. So big surgery, GBR, place the implant. Sometime I was doing a temporary crown to get some aesthetics, and after that the final crown. But in those non-aesthetic area, I always forget about soft tissue. And when you see those molar with buccal loss of tissue after a few years, you have to ask to tell the patient, the implant is great, but if you want to keep it great, you need soft tissue. It's like if the tooth has a recession, you put soft tissue. The implant is getting thin, place soft tissue.
Do you find it more difficult to place a soft tissue graft on an already existing implant site or,
Yes,
um,
yeah, it's a bit difficult around implant crown.
yeah,
Uh, some molars, I remove the crown if it's screw retained sometimes to get better access.
yeah,
Especially if I did the crown, I will remove it because I know how it's been made, and I got a protocol how to torque and everything, and I know the implant. I put it myself. But if it's an old crown, an old implant, sometimes I'm too risky for me to play with it. I don't know what's underneath there. If it's cemented, I don't touch it. You go around. Sometimes the result is not as good, but it's better than doing nothing.
yeah. No, I 100% hear you. I feel so happy. You've made my day just by looking at this case because I know what's possible now. This is great. But as we know, not all soft tissue goes how we want it to. Am I right?
Yeah, you asked me a few days if you ever had a failure, and you know what? I did have a failure like 3 weeks ago. Classic stuff, CTG around a tooth, and something happened. So let's look at the case.
Yeah.
So for me, this is a basic case.
Whoa,
I
whoa.
do
In my
that.
office, I tell them, you know what? It's okay. Everything will be fine. It doesn't look like it's progressing. Let's just leave it. This is what I say
Yeah.
because I don't want to deal with it. But anyways, let me see. Let me hear what you say.
Hey, patient is the mid 30s. Patient brush too hard. Patient has recession. Has the
Yeah,
same recession on the other side. Is getting some sensitivity on the tooth, and he's been told, yeah, one day you're gonna need a graft. One day you're gonna need a graft. So patient came to my office as a new patient, and I say, well, yeah, Have you? Did somebody explain to you what's going on with that tooth? He said, yeah, I see the roots. Something is wrong, and now I have pain to the coal and everything.
yeah,
So he asked me, "Do you know somebody who can do that?" And I said, "Yeah, I can do it for you."
yeah. Me.
Uh, so for me, it was not too bad.
Yeah,
I think the biotype is good around those other roots. The tissue is pretty good. Uh, but looking at the case right now, there's bony exhaustos there, and maybe that's part of the problem. Maybe the tissue was difficult to move around. Maybe it was thinner than I thought. Um, so I did a CTG from 15 to 16 because I wanted a big piece. So a molar is pretty wide. You need a big piece to cover it to be secure. And it was starting to see a little bit of the roots on the number 15. So my CTG goes from 15 to distal of 16, and everything looks good. Classic day, classic result. So this is just a few at the end of the appointment. I just snap a picture before the patient goes away. Uh, so we see the tissue has been moved down. I did share that case in another group. I'm pretty much involved, and I got a lot of discussion out of this group. Is there too much tension? What going on and everything? But for me, during the surgery, everything looks good. Didn't think it was too much pressure. It's a very good patient. I think he did follow the rules. He did follow the all the protocol. But
Yeah.
he called me. I never really, almost never had call from patients. So on Fridays, I give them my cell so they can phone me during the weekend if they have pain. After that, there's surgeries, and most of the time they call me because they don't know exactly which medication to take. But that's about it.
Yeah.
Um, that patient called me 2 days later at the office and say something is wrong. I have lots of swelling. I have major pain. It's not going like you explained. So I saw the patient 2 days later, and he has a huge bruise underneath his cheek, and it was all bluish underneath there. Um, I don't have a picture of it, but it was very not looking good. So I no, I tell the patient everything looks okay except the bruise. Put him on antibiotics, which I usually don't do, but just in case it doesn't heal properly, and say, I want to see you next week. And he came 5 days later with this.
Whoa.
So something went wrong. So
Wow.
it looks like the graph is still on 15. I don't know. But he lost everything on 16. Now it's worse than it was.
Yeah.
And the pain level is really high. It's very high. So I saw the patient every week for 3 weeks. It healed properly. The pain is almost gone. It's back to what it was, but the tissue doesn't look good at all. So we have to redo that one, and we have to find a different way to do it because I'm not going to do it the same way again.
What do you think went wrong there?
Probably not enough release, or maybe the graft was not attached properly underneath the flap. That's what's the main thing. I didn't use maybe enough sutures to secure the graft underneath the flap, and maybe with the swelling, it moved and didn't get any nutriment from the blood flow. Maybe the bruise didn't get some good vascularization, and the graft just went away.
Wow. Man,
So,
that's, to me, that it makes me know that you're human because I've seen your cases. They are incredible. And, this is something any of us could get. It could
yeah,
be that there was dead space in there and the graft just wasn't adapted as nicely to that
that's it.
root as you wanted it, right? So,
Yeah,
and then bacteria gets in and it's game over.
yeah.
Well,
I think
you
it's a
mentioned,
combination of swelling, dead space, like you told. You explained not enough. The graft probably underneath was not secure enough,
yeah,
and it did move somewhere and just get expulsed, necrose, and that's it.
but you know what? At the end of the day, we're all human and, it just happens to the best of us, I guess. Hey,
Yes, it does
it
happen.
happens.
The good thing, it doesn't happen very often, but I told the patient, 100% I'm going to redo it in the next few months for you. I stand by my work. If it's not your fault, we're going to do it again.
I like that because you got to take care of your patients. Now, I
Yeah.
want to ask a guy like you who has so much experience. You've been a dentist for 30 years. What do you struggle with?
What do I struggle with?
Yeah, like
Uh,
what do you find difficult about dentistry now? Like what parts are you like, I don't want to go into work today?
um, Even if I like surgeries, it's the selling of the surgeries to the patient. If I can just do my job without explaining too much and justify the cost and the investment to the patient, I would like to do implants all day long. But, even if you have a team, you all feel the pressure of selling your dentistry. You have to talk to the patient, get involved with the patient. That's good. I have some patients who see me for 20 years now, 25 years, and they've been very loyal. But every day with a new patient, you have to start again this step of, yeah, dentistry costs money, but you have to do it. And I think we're the one that you should do it with. Sometimes I don't get the energy to sell dentistry. It doesn't sell by itself. Even if you're confident with your soft tissue, I do a lot of them, but a lot of patients walk away. And that's the hard part. I would like to do like easier treatment planning the patients. I have some patients, if it's not covered 100% by the insurance, they will never, never, ever do
Right.
it.
Yeah. No, I totally hear you. Talking to patients about money can be difficult. We understand that, good dentistry does have a price because you can always find dentistry cheaper, but then, you end up redoing it. I hear that. But Alan, we have to end this on a good note. What excites you? You've been a dentist for 30 years. What gets you up every morning? What makes you
I,
you, man?
I like to push the envelope. I like to learn stuff. That's why I'm involved with different groups,
Yeah.
with bites. I like to share what I learn. I like to try new stuff. I like to do stuff that I know, but on a higher level. Uh, had this great mentor 20 years ago told me, take pictures of everything you do, you're going to learn so much out of it. And now I take my pictures and try to share it with others. I was very shy of showing my pictures the first 10 years because there's always somebody better than you. But after a while, you get over that. And I like to mentor. I like to touch new dentists, young dentists. I'm very happy to be involved with my ITI group the past 3 years. We are 30 members there. Most of them do average level of dentistry, average level of surgery. But if I can influence them moving forward, that makes my day.
Man, and that's honestly, that's what it's all about. It's all about serving others, and you're serving them through your passion for dentistry. And I would love to, have you mentor me on some cases, and I would be honored to take a course from you in the future if you ever have one, because you're, like I said, you're the GP that a lot of us are striving to be. So thank you so much for spending your time with us for the past hour. I know you're a busy guy, but thank you. I learned a lot, and I still can't get over that locator case you had, all that free gingival tissue. I got a couple cases like that coming up, and I'm going to go back and look at your posts and study up. So thank you for joining us, my friend.
Thank you. It was a pleasure talking to you.
Awesome. To everyone that joined in, thank you so much. And we'll see you guys again next week. See you later.
Thank you.
See ya.